So the usual infections in diabetes include the urinary tract infections, pneumonia, tuberculosis, folliculitis, diabetic foot with sepsis, candidiasis, and SARS-CoV-2. And unusual infections or uncommon infections in diabetes include the rhino-orbital cerebral mucormycosis, the emphysematous pyelonephritis, emphysematous cholecystitis, and malignant otitis externa. So I'll be mainly focused on the unusual infections in diabetes, which being a referral center at our place. So we see even these unusual infections more commonly in our scenario. I'm not talking about the common infections because most of the physicians are aware about that. So that's why I thought that I will apprise the people which we have worked in last 2 decades on these unusual infections in diabetes. I will also not be covering the SARS-CoV-2 because already there is one full session on this. So question is why there is a concern for infections in diabetes. Of course, this may not be a problem of the Western world because in the Western world, the major cause of mortality is being the CAD and end-stage renal disease. While in India, we published data way back in 2003. So it's old data, but still it's relevant in our scenario that the sepsis was contributory for the mortality around 50%, 46%. And the pulmonary, foot, and others, they were the main causes for the infections-related mortality, while the CAD and ESRD and seasonal disease contributed only about 17% and 9%. So total is 1/4 of the mortality was because of the CAD and ESRD as opposed to almost 80% in the Western world. So the major cause of mortality, even in the Indian scenario, was the sepsis, and this was further endorsed by Dr. Zargar's data, which they published way back in 2005 or 2007, and they again showed that the infection continued to remain as one of the important causes of mortality in patients with type 2 diabetes. Are infections common in diabetes? I think there are many conflicting reports, which some says yes, there are more predisposition, and some says there are no. But eventually, there is one consensus is that the frequency is similar, but the severity is more than non-diabetics. I think there's no denial in that. And the same thing is for SARS-CoV-2. The frequency of SARS-CoV-2 with higher mortality was with higher aggressiveness was more in diabetes as opposed to non-diabetes, but the frequency of the SARS-CoV-2 was similar. The severity was much more. We further analyzed this data and showed the cause-specific mortality in diabetes in our hospital-based population. And so here you can see that the patients with diabetic versus non-diabetic infections again was more common in diabetic than in non-diabetic. Accidents and malignancy, they were less common, the more common in non-diabetics. The CAD, ESRD, and CVV, they were more common in diabetics. So you can see that even in hospitalized admissions, the infections predominate in diabetics as opposed to non-diabetic, while the CAD, ESRD, and CVV are other important causes of mortality in a hospital setting. Why infections are common in diabetes? Because of the lazy leukocyte syndrome. And this leads to decreased capability of the neutrophils for adhesion, diapedesis, and phagocytosis. The high glucose milieu itself serves as a good nutrient media for that. The associated diffuse vasculopathy and endothelial dysfunction also contributes to more severity of infection in diabetes, and associated neuropathy because the vascular tone is also maintained by or vascular reactivity is also maintained by the neural system. So if there is a concurrent neuropathy, then the, the vascular mediated phenomena related to infections are also impaired. A word about the ROCM, that is a rhino-orbital cerebral mucormycosis. So this is the data which we published in Postgrad Medical Journal way back in 2004. And this was the 35 patients of the rhino-orbital cerebral mucormycosis. And this was the ophthalmic signs and symptoms. And you can see that the ophthalmoplegia, proptosis, and loss of vision were the very common symptoms. And even some patients presented with eyelid necrosis. So this was the data which we published in this. And even the central retinal artery occlusion was one of the common findings and observed in 20% of patients with ROCM. Then the frequency of the different signs and symptoms, if you see that the The concurrent symptoms and signs include sinusitis, nasal discharge, facial swellings. Seventh nerve palsy was also seen in 46% of patients. And you can see that other features were also there present in our patients. So that was one of the presenting manifestations of these patients of ROCM. So this is one of the patients which you see with the type 1 diabetes and who presented with bilateral eyelid gangrene. And you can also appreciate even the skin over the nose that is also gangrenous. So this is one of the very classical and very one of the severe manifestations of rhino-orbitocerebral mucormycosis. And you can see that this is on a CT scan, and you can find out the whole ethmoid gallery, the maxillary sinus and the sphenoid sinus, they are loaded with fungus. And this is also, you see that these are one of the orbital component. Here again the ethmoid gallery and the orbit is involved into the by the fungus. And this is one of the patients who had the involvement of the cerebral parenchyma by the fundus, and there was a cystic structure formed after this. So you can see that the patients manifested with features of raised ICT. And this was one of the patient who underwent autopsy, and we could show that the involvement of the cerebral parenchyma by the fungus, and the typical fungus is, which you see in histopathology, is a right angle branching and aseptate hyphae. That is a very, very characteristic of this fungus. The treatment of the rhino-orbitocerebral mucormycosis predominantly involves the early recognition. If you recognize it early and you just take a sample nasal scraping or the sinus scraping and immediately start the treatment with amphotericin. But remember, the debridement is very, very important. When initially we mainly focused on amphotericin B, again the outcome was poor, and when the only confined was to surgery, then again the outcome was poor. So combine both the modalities very aggressively, so the outcome is around 70 to 80% of the patients, they do recover. Certainly, we have found more number of patients even after COVID because of the possibility, because of the use of steroids, or rather abuse of steroids, concurrent use of zinc in patients with COVID. So there was again a high incidence of mucormycosis in patients with COVID. The factors which are associated with the poor outcome in ROCM included the delay in diagnosis and treatment, the facial and lid gangrene, patients who presented with ophthalmoplegia, hemiparesis, and those who received amphotericin B alone, they did poor, as opposed to those who did not have these clinical manifestations and underwent combined treatment with amphotericin and surgical debridement. Another dreaded manifestations in patients with diabetes is emphysematous renal tract disease. Here, the two important entities, emphysematous pyelonephritis and emphysematous cystitis, and it's one of the common causes in patients with diabetes presenting as a PUO. And the predisposing factors for emphysematous renal tract disease includes neurogenic bladder, obstructive uropathy, either because of stricture stone and papillary necrosis. So this was the data which published in 2006 of 20 patients of emphysematous renal tract disease. And you can see that the fever, flank pain, and the gross hematuria. And even the 35% of the patients had a history of hematuria. That was one of the important manifestation. And acute renal function impairment was consequent in all as expected. And even as a presenting manifestation of diabetes, the 15% of the patients had this. The organisms is not the Clostridia, but it's E. coli and mainly gram-negative. And these gram-negative organisms, because of the hypoxia or because of the tissue anoxia, they produces a more gas, and it is mainly, usually it is a carbon dioxide and hydrogen sulfide, which is usually there. And the gram-negative organisms are responsible for increase in gas production. And the management and outcome, if you look into that, it's again, the mortality was high. We can see that the 9 out of 20 patients, in fact, died. So this is mainly because if the diagnosis is delayed, one, secondly, they're already in a septicemic state, and lastly, it is a bilateral disease. So here we can see that the gas, even on a plain X-ray, could be identified. And this is a CT scan which showed, you can see that On a left kidney is normal, on the right kidney, you are finding this hypodense area suggestive of the emphysematous pyelonephritis. And again, you can see that the whole kidney of the left kidney is completely destroyed by the emphysematous pyelonephritis. And again, here you can see that it's a emphysematous cystitis, where you can see the presence of air in the urinary bladder, and the patient was presenting with pneumochuria. The treatment includes early recognition, again, isolation of organism and appropriate antibiotics, the pictal drainage in some of the cases. Otherwise, we have gone for a nephrectomy and supportive measures, including dialysis. The other emphysematous disorders, we had an opportunity to see, in fact, both the combination of the two, the emphysematous cholecystitis and emphysematous pyelonephritis together. And again, you can see that here the G is marked as a gallbladder, and you can again find a gas in the gallbladder. And the organism which is here in this patient was E. coli. But usually, the emphysematous cholecystitis is usually a manifestation of the Clostridia because it is coming from the gut, while emphysematous pyelonephritis is usually a manifestation of gram-negative organisms, particularly E. coli. And this is again a patient with emphysematous cholecystitis with pyelonephritis. And lastly, a word for the preventive strategies in patients with diabetes for prevention of infections. And this is influenza vaccine, which is annually recommended, the pneumococcal vaccine according to the dose schedule, and the hepatitis B vaccine. So I think the vaccination schedule should be introduced in patients with diabetes to reduce this. Certainly, for COVID, we have already recommended the booster dose in our country. So even that administration of COVID vaccine has really led to decrease in severity of the disease, even in patients with diabetes. So to conclude, infection is still a major cause of morbidity and mortality in diabetes. The diabetics have a predilection for certain infections, mucormycosis and emphysematous renal tract disease. Diabetic foot and sepsis, I didn't deal, but this is a very important cause of mortality, particularly osteomyelitis. An attempt should be made to prevent infection as a cause of mortality in diabetes, rather than treating a full-blown disease. Then it is really difficult and associated with higher morbidity and poor outcome. Thank you. Thank you for your patience hearing. Any questions or any comments, I'll be happy to answer.